This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference. As you can see, our presenter this morning is Dr. Rachel Tobin, one of our first-year fellows. For those of you out there that maybe haven't, faculty that maybe haven't met her yet, Rachel, Pittsburgh originally. Or you grew up in Pittsburgh?
Pittsburgh, yes.
Yeah, originally from Pittsburgh, undergraduate at Emory, and then Duke for medical school and residency. As you can see, she's going to talk to us about late presenting STEMIs. So take it away, Rachel.
All right. Thank you, Dr. Williams, for the introduction, and good morning, everyone. So I'm excited to talk to you about a topic that I've titled The Late Presenting STEMI, a tale of two STEMIs and the importance of time. And these are actually two cases that I've seen at the VA on my cath months for the last 3 months. So first, no disclosures. Objectives today, we're going to talk about what is considered a late presenting STEMI, describe the clinical impact and complications of late presenting STEMIs, identify factors that contribute to delay in patient presentations and areas for improvement. So first, starting with two patient cases, patient 1 and patient 2. Patient 1 is a 52-year-old male. He has a history of hypertension, hyperlipidemia, obesity, sleep apnea, and diabetes, prediabetes, who came in with chest pain. And his chest pain was left-sided, sharp, radiated down the left arm. He's never had any pain like this before, and it increased in intensity, and he had associated dyspnea and diaphoresis. Our second patient is a very similar story. He is a 66-year-old male, history of diabetes, hypertension, hyperlipidemia, former smoker, came in with chest pain, which was a similar description. He developed substernal chest pressure, increasing in intensity and constant. He has hypertension and checked his blood pressure at home, which was elevated compared to his usual average. He got 160 over 110. He did try taking Tums, but it didn't relieve his symptoms. And the biggest difference between patient 1 and patient 2 is patient 1 presented to the ED 30 minutes after his pain started, whereas patient 2 presented 3 days later. So going through patient 1's story, so here's his EKG and vital signs when he arrived to the ED. He was hypertensive. And what stands out here is the ST elevations and the inferolateral leads. His troponin, again, this is 30 minutes after the onset of chest pain, was negative. Essentially, this is troponin I, was 0.03. The cath lab was activated, and the first thing that we thought was, could this be RCA STEMI? Was that the culprit lesion? So we shot the right coronary first, which, as you can see here, is overall a pretty normal right coronary artery. This was not the culprit lesion. We looked at the left system. Actually, the artery that we expected least seemed to be the culprit lesion. So I'll let this play again here. So looking at the LAD coming down in RAO cranial, there's a hazy lesion here that appears to be some thrombus and plaque that's eroded. And then looking down, this wraps around the apex, which explains the inferior ST elevations. Here is another view, RAO caudal. You can see that same lesion up here. So because there was thought there was a lot of thrombus and clot based on the angiographic imaging, we did do aspiration in this case, aspirated some of that thrombus. That area was ballooned and stented, and here's our final angiographic result. I'll let this play one more time here. Our patient did get an echo since he presented with a STEMI as part of his post-STEMI care. I will zoom through this because the punchline here is this is a pretty normal echo for someone who presented 30 minutes after quick reperfusion. He did not have any wall motion deficits and a pretty normal echo here. His clinical course, he did quite well. So he was observed for 24 hours in the CCU. He started on dual antiplatelets, high intensity statin, beta blockers, and ARBs. He wasn't on any of these medications prior to admission. Actually, the next day he was ambulating in the VA CCU, doing well and discharged, and he was seen back in cardiology clinic, doing well and interested in cardiac rehab. So now we'll contrast this to patient 2, similar risk factors and story. He's about 10 years older than our first patient, who did come in 3 days after his pain started. Again, vital signs EKG, he's hypertensive and borderline tachycardic. We have ST elevations and Q waves here. Our previous patient did not have Qs in the inferior leads. 3 days after the chest pain, his troponin was 80, and this is troponin I, and his BNP was 321. Here's his cath. I'll start by showing you the left system. What jumps out here is the circumflex system. I'll play this again here. This is our RAO caudal view. Looking at our circumflex system here, there's pretty much complete occlusion after that first OM. The LAD, our views here aren't great in the setting of the STEMI. I'll show you a cranial view, but the LAD did have disease that we called about 60 to 70% prox to mid, and the RCA was diffusely diseased as well, about 70% proximal and 90 to about 100% even distally. But looking at our RAO caudal view, we thought the culprit lesion was this circumflex. And the patient, I'll tell you the reason why he was taken to the cath lab 3 days after presentation is he was still having active chest pain that we were not able to control with medications. So we were able to wire down the circumflex. Here's a picture of that wire here. Balloon and stent, and here is our final angiographic result. We do get flow now in that circumflex artery that we did not have before. I'll play this again here. His clinical course and echo were not quite as favorable as our first patient. So first, starting in our parasternal long axis view, his EF is around 35%, has a trace effusion here. He has hypokinesis of the lateral, inferior, and posterior walls. I'll play our additional views here. We'll go one more time. Here's parasternal long, parasternal short axis. Here's a 5-chamber view and 2-chamber. The other piece that stuck out from his echo is he developed moderate to severe MR. And as far as we knew, he did not have an echo beforehand, but we assumed he didn't have any mitral regurgitation. He's never had any heart failure symptoms, murmurs, reasons to have MR. So here's a view of that moderate to severe MR. And then here's our Doppler tracing. I'll play this one more time. So his clinical course was much more complicated. He continued to have chest pain even after the cath, and his chest pain changed in quality. He now described it as pleuritic and positional, whereas before it was crushing substernal, the classic MI story. He also developed a friction rub-on exam, a leukocytosis, and was febrile to 101. He was eventually treated for post-MI pericarditis, and that echo, we saw just a trace effusion with high-dose aspirin and colchicine. He, compared to our first patient who had a little over 24 hours in the hospital, spent 8 days in the hospital and was actually readmitted for additional 4 days for continued chest pain. And he did have a repeat echo at this time, looking at the effusion and the MR, and everything was stable. He never developed cardiogenic shock, thankfully, as a result of the MR. 1 month later, he did return for stage PCI to the LAD. The LAD was FFR'd first before any intervention, and we got 0.76. Here's a picture, a better shot than our STEMI photos of that LAD pre-intervention and LAD post-intervention. And when we saw him for the cath, his chest pain had actually resolved after being on high-dose aspirin and colchicine, and he was starting to get back to some of his normal activities. So these two true patient cases that I've seen at the VA on my cath months inspired this talk of late presenting STEMI. So first, let's start by talking about what is considered a late presenting STEMI. So a late presenting STEMI is after 12 hours of symptom onset. And you might ask why 12 hours, and it's actually interesting where this comes from. So the 12-hour definition comes from the thrombolysis era, way before we were doing PCIs on these patients. There was the late study about 30 years ago that was published in the Lancet that showed thrombolysis showed no benefit after 12 to 24 hours after the onset of chest pain. However, on more modern days, what to do with patients who arrive greater than 12 hours remains a topic of debate. So who needs primary PCI? And the guidelines between the US and Europe actually differ. The US guidelines are older than Europe, from 2013, our most recent guidelines. So for class 1 indications, we're pretty familiar with these: ischemic symptoms, and this is STEMI, less than 12 hours. Ischemic symptoms less than 12 hours with contraindications to fibrinolytic therapy despite delay from first medical contact, cardiogenic shock despite delay. And then this is sort of where we're talking about these patients, evidence of ongoing ischemia 12 to 24 hours after symptom onset. Whereas the ESC guidelines, they're similar. So class 1 indication for patients with time from symptom onset greater than 12 hours, primary PCI strategy is indicated with ongoing ischemia, hemodynamic instability, or life-threatening arrhythmias. However, in contrast to the US, they actually say for patients in that 12 to 48 hour range, a routine primary PCI should be considered. Whereas US says only in patients with evidence of ongoing ischemia 12 to 24 hours after symptom onset. So patient 2, who I presented to you, had continued chest pain, which is why we took him to the cath lab. So how often are patients actually presenting late, presenting greater than 12 hours? I'll show you data from 2 registries. The first is one of the more modern registries, so STEMI. This is data from France, and they looked at a little over 6,000 STEMI patients from 2005 to 2015. In 2005, 22.7% of patients were presenting late is what they quoted, whereas in 2015, that number dropped to 16.1%. They did estimate that approximately 1 in 6 patients still are presenting greater than 12 hours after symptom onset. And then here's another registry from the US, a little over 5,000 patients. This is interesting because it also involves COVID data. So in 2003, pre-COVID, their estimates were lower, that 6.2 patients were presenting late, greater than 12 hours, whereas that number increased to 11% during COVID. A couple of caveats to their data set is 27%, so a little over 2,000 patients were excluded due to missing data of when exactly their chest pain started. Additionally, it doesn't include patients who passed away pre-hospital from out-of-hospital cardiac arrest. And if you look here at this graph from the paper, this is your 12 to 24-hour patients. Blue is before COVID. Red is during COVID, that they show that there are later presenting patients actually during the COVID time. So patients were not wanting to come to the hospital. Who presents late? There's a lot of different factors in the literature that are associated with late presentations. So older patients, especially patients who are older than 70, are presenting late. Women are more likely than men to present late. Those with diabetes, I think diabetes is sort of the classic teaching that they may not feel the chest pain is similar to other patients. Also hypertension, and then cancer, heart failure, stroke, sicker patients at baseline are also presenting late. African Americans are presenting later than whites, and Medicaid-only recipients compared to Medicare and privately insured patients. And this makes sense. If patients don't have chest pain, they're more likely to present late. They may have atypical symptoms and not think they're having an MI. So why exactly does time matter? Why the importance on time? This starts actually from the 1970s. This was a paper published in Circulation in the 1970s. And what they looked at is in dogs, they actually occluded the circumflex artery and took slices and then looked under the microscope of the papillary muscle. And if you look to the left here on this slide, top is subendocardium and bottom is epicardium. And they looked at slices under the microscope at 40 minutes, 3 hours, and 24 hours. At just 40 minutes, these slices had subendocardial necrosis, and about 38% of the myocardium was necrotic. As time went on, 3 hours later, 57% of the myocardium was necrotic. And at 24 hours, 85% of the myocardium had necrosis and almost transmural necrosis at 24 hours. On the right here on the slide is another image of essentially the same thing, percentage of viable and potentially salvageable muscle as a function of time. And it's essentially 0 to 24 hours and percent of salvageable myocardium. And this number steeply drops quickly and almost goes down to essentially 0, close to 24 hours. Then came the idea of total ischemic time. Total ischemic time is the time from symptom onset until reperfusion. And looking here, there's data from 3 separate curves. The red curve is actually the same curve that's on the right here. This is that data from the dogs back in the 1970s. And you can see that curve quickly goes down over time. The interesting thing about this slide is it overlaps almost identically with two other data sets. So green is myocardial salvage index from MRI scans, and that looks very similar to the red line here. And then blue is patient outcomes from a more recent data set. And almost all three of these have the exact same curve and slope. If you look here, before 120 minutes, there's a slope that's much steeper than after 120 minutes. Where these two lines intersect is around the 120 minutes, which defines the cutoff for optimal outcomes in a lot of modern studies. And this is again from symptom onset until reperfusion. Mortality is another important topic to talk about with time. So here we're looking at 1,700 STEMI patients who were treated with primary angioplasty. And this was published in Circulation in 2004. What you can see here is that as ischemic time increases, so does mortality. And in red here is that 120-minute line. And what's most interesting is for each 30-minute delay, 1 year mortality actually increases by 7.5%, which is a huge difference for each 30-minute delay. Next comes the BRAVE-2 trial. So this is published in JAMA in 2005. And this trial is BRAVE-2 comes from beyond 12 hours reperfusion alternative explanation or evaluation. And what they looked at here was this group is smaller than some of the other trials that we've talked about thus far. They looked at 348 patients with STEMIs between the ages of 18 to 80, and they looked at between 12 to 48 hours after symptom onset. Patients were randomized to invasive strategy with abciximab versus conventional conservative treatment. And here you can see the Kaplan-Meier curves for their primary outcome of death, recurrent myocardial infarction, or stroke for conservative invasive treatment groups. And although these curves do separate days after randomization, it's not statistically significant. However, this is a much smaller patient cohort than some of the other trials that we've already looked at. Interestingly, so their primary outcome was not this composite of death, myocardial infarction, or stroke. It was actually final LV infarct size via SPECT, and it was significantly smaller in patients assigned to the invasive group, which was 8% versus conservative group 13%. So all the data we've talked about has been patients presenting sort of in that 12 to 72 hour range, but what about patients who are presenting even later? Which comes the OAT trial, which is the occluded artery trial, which was published in the New England Journal of Medicine in 2006. The occluded artery trial included a little over 2,000 stable MI patients. And I will say the caveat with this trial in comparison for the rest during this talk is they did not just have to be STEMI patients, but patients with total occlusion of an infarct-related artery 3 to 28 days after presentation, and they also had to have a high-risk criteria, meaning an EF less than 50% or proximal occlusion. Primary outcome here was composite of death, MI, or New York Heart Association Class 4 heart failure. And looking at the hazard ratio here and the p-value, there was no statistically significant difference between the PCI group and medical therapy group and these patients presenting 3 to 28 days after MI. The caveat I have here for you is mean time to randomization was actually 8 days after presentation of the MI, and patients did have PCI within 24 hours of randomization. So it could be up to 9 days from when these patients presented, whereas other trials that we're looking at are all less than 72 hours. So what about more modern contemporary data? A study just came out in 2021 entitled Percutaneous Myocardial Revascularization in Late Presenting Patients with STEMI. This was published in JACC, and this is actually data from that French cohort from that FAST-MI database. They looked at latecomer STEMI patients, so they called latecomers here 12 to 48 hours. On average, the patients were 65 years old, 31% female, 21% had diabetes, 22% atypical chest pain, and about 70% came in via EMS. And this was a little over 6,000 patients. They were randomized to either revascularization versus no revascularization. The patients who were revascularized happened to be a little bit younger, 63 versus 70. Lower females, 28% compared to 38%. And then KILP scores and GRACE scores are listed below. Here's the data that from this study looking at revascularization compared to no revascularization, and pretty dramatic difference between the two groups. So at 30 days, the revascularized group, the mortality was 2.1% versus 7.2% in the group without revascularization. And when they calculated long-term mortality for 1,000 patient years, the revasc group had 30.4, whereas no revasc was 78.7. Both of these values are statistically significant. And the p-value was for the hazard ratio, here's our hazard ratio is 0.65, and that was also statistically significant. And again, this data came out of France, and we've already talked about differences between US and European guidelines, but this is likely one of the reasons that the Europeans recommend a routine primary PCI for patients presenting late, 12 to 48 hours after symptom onset. What about imaging evidence of the effects of time? I showed you on that one curve that there was some imaging data, but here's a study in the European Heart Journal in 2009 looking at infarct size and myocardial salvage after primary angioplasty in patients presenting with symptoms for less than 12 hours versus 12 to 72 hours. What they looked at here, they looked at final infarct size and myocardial salvage in early presenters, so less than 12 hours, they had 341 patients versus late presenters greater than 12 hours. This was 55 patients. And they used myocardial perfusion imaging with SPECT prior to angioplasty and 30 days later to assess the final infarct size, salvage index, area at risk, and the LVEF. So this is sort of a busy figure here, but let's start by just looking at the left and I'll walk you through this. So all patients, the area at risk is actually before from the imaging before the PCI. So as you can see, as time goes on, more area is at risk. And then these are from after. So infarct size gets larger as time goes on. Salvage index, percent of area at risk, afterwards goes down, less salvaged as time goes on. And then EF does drop as time goes on from presentation. The important thing here is actually when you look at the data to the right, it's important to note that even in patients who had complete occlusion of the artery, there was still substantial myocardial salvage despite symptom duration of 12 to 72 hours. So again, looking here, area at risk beforehand, infarct size goes up, salvage index does go down, but there's still a lot of myocardium that can be salvaged. EF does go down as expected as well. Now we're going to jump into this portion of the talk. We're going to talk a little bit about how we're doing in terms of getting patients to the ED, to the cath lab, and areas for improvement. So these metrics are from the ACC-AHA, and essentially they recommend from the STEMI guidelines, EMS time should be less than 15 minutes. When a patient arrives in the ED to when they first get an EKG, it should be less than 10 minutes. If they need to be transferred, the door in, door out time, less than 30 minutes. And then first medical contact to device for non-transfers is less than 90 minutes that we're all familiar with. The first medical contact to device for transfers is less than 120 minutes. And if anticipated to be greater, then patients should get lytics within the first 30 minutes. I like this slide here. This talks about the pathway for directly admitted patients versus transfer patients. And again, we have symptom onset to EMS time, the transport time, so time from EMS to PCI capable receiving center, and then time to PCI. So 3 variables here: patient time, transport time, door to balloon time. And again, this gets more complicated in transfer patients. Thankfully, we don't have to deal with this very often, but transfer patient time, transport time, door in, door out time, transfer time, and door to balloon time. An area of interest of mine that I was interested when I was doing reading for this talk is actually patient time. Because if patients are presenting late, let's say they present 6 hours, 3 days after the onset of symptoms, have we already lost the battle at that point? So looking at data on pre-hospital delay, so most patients with STEMIs actually don't seek care for approximately 1.5 to 2 hours after symptom onset. And this figure is from 2009. This is showing data from STEMIs and unstable angina across various countries around the world. So US and Canada are in blue here. And their average delay for STEMIs is around 2 hours, similar to Australia. Europe is a little bit longer, about 2.5 hours. And then Argentina and Brazil, even a little bit over 3 hours. However, over time, this is from 2010 in European Heart Journal, unfortunately, symptom to door time really hasn't improved. So looking at the bar graphs here from 2003 to 2007, if you look at 2003 to 2007, they look almost identical, and there's really not been a lot of improvement over time. So why do patients delaying? Why aren't they coming directly to the hospital when chest pain starts? And I put this in a circular format because a lot of these overlap, and a lot of it is a spiral for patients. So there's stereotypes among who's at risk for a heart attack. This is common among women that they're not at risk. Pre-existing bias of what exactly an MI should feel like. It should be crushing chest pain, and a lot of patients, maybe 30% of patients, don't even have chest pain when they have a myocardial infarction. Thoughts that symptoms will be self-limiting, that this is sort of my patient 2 for you, that it's probably going to go away, I'll just wait it out at home, might be related to other pre-existing conditions, his hypertension or GERD. And then fear of embarrassment if causing false alarm was a big one in the literature, that a lot of patients are afraid of actually embarrassment if their workup is negative. What about transport to the hospital? So if patients decide to come into the ED, how are they getting there? So over 98% of the US is actually covered by 911, but only about 60% of STEMI patients are actually coming via EMS. Those who are transported via private vehicle, approximately 1 in 300 patients will have a cardiac arrest en route. This is all from the ACC/AHA STEMI guidelines. There is a significant association between arrival to the ED by ambulance and earlier delivery of reperfusion therapy. Pre-hospital EKGs is another big way to save time for patients. They're associated with shorter reperfusion times and lower mortality rates. And this makes sense, especially off hours. I think we've all been through this. You get the call activated before the patient's even there. It gives the cath lab team a lot of time to get there, 15, 20 minutes before the patient's even at the hospital. When the patients get there, so how is door to balloon time doing? So this is New England Journal 2013, door to balloon time and mortality among patients undergoing primary PCI. We'll start by looking to the right here. So overall, door to balloon time is getting better. And that's our orange line here. Looking from 2005, 2006 to 2008, 2009, median door to balloon time overall has gone from 83 minutes to 67 minutes, much better. But mortality, there's no significant difference. For older patients, they're also improving, 92 minutes compared to 73, no difference in mortality. Anterior MIs improving as well, again, no mortality difference. And then same with cardiogenic shock, also improving around 88 minutes to 69 minutes, no difference in mortality. And then another way to look at this is a mortality according to the door to balloon time. So on the left here is patients with door to balloon time less than or equal to 90 minutes. You can see that is going up about 83% here. And then here, patients with door to balloon time greater than 90 minutes percentage is going down. So 16.9%. Mortality for patients unchanged here. However, this was interesting and significant. Mortality did increase despite door to balloon time going down for patients who presented late. What about, the ideal system, patient education, quality improvement efforts? So the American Heart Association has developed Mission Lifeline, which is a quality improvement project to get patients to the hospital faster for not only STEMIs, but also out of hospital cardiac arrest and STEMIs and strokes. And they've developed a lot of metrics from cardiac arrest to community outreach, EMS being on the scene, getting patients triaged to either a PCI capable hospital or a PCI non-capable hospital for transfer. Patient education is another big thing out there, which I think is great. The AHA and NIH have developed this campaign that they entitled Act in Time to Heart Attack Signs. And they this is one of their posters that, chest may hurt, but there's a lot of other symptoms that could represent a heart attack, such as pain in arms, pain in neck, feeling short of breath, feeling dizzy or lightheaded, or feeling nauseous. Complications of late presenting STEMIs, I think, could be an entire topic in itself. The later the patients present, the more likely they are to have these various complications from ventricular thrombi and embolisms. Cardiogenic shock, decreased contractility could be an entire talk in itself as well. Electrical instability, arrhythmias from out of hospital cardiac arrest to arrhythmias in the cath lab and afterwards. Tissue necrosis, so papillary muscle infarction and ischemia, leading to mitral regurgitation and heart failure. Ventricular septal defects, ventricular ruptures, and interestingly, there was actually a whole issue of a lot of these cases presented during the COVID times when patients were presenting later. And then pericardial inflammation and pericarditis and potential tamponade. For this talk, going back to my patient 2, the patient who presented 3 days after the onset of chest pain, he had both mitral regurgitation and pericarditis. And I just want to take a couple of minutes and talk about the management for pericarditis and a little bit about post-STEMI MR, because it's interesting and pericarditis is treated quite differently than we're used to. So post-MI pericarditis, aspirin is recommended for treatment of pericarditis after STEMI, and this is a class 1 recommendation. Tylenol, colchicine, narcotics could be reasonable if high-dose aspirin is not effective. Our patient was actually on 650 milligrams 3 times a day plus colchicine. Glucocorticoids and NSAIDs are potentially harmful after STEMI, so class 3, due to the risk of hemorrhagic conversion. And the same is true for anticoagulation, that patients could potentially be harmed by anticoagulation due to potential for hemorrhagic conversion. Obviously, all these patients post-STEMI need to be on dual antiplatelet therapy, but adding additional anticoagulation could be harmful. Mitral regurgitation after STEMI, here's that picture from our patient who presented 3 days later. So it usually occurs via papillary muscle rupture or post-infarct LV remodeling with displacement of the papillary muscles, leaflet tethering, and annular dilation. Most often affects the posterior medial papillary muscle because it has a singular blood supply. An acute severe MR is characterized by cardiogenic shock and edema. A murmur actually may not always be present in these patients. Mitral valve replacement rather than repair is usually required. It's associated with about a 20% risk of mortality if patients do need surgeries. In 5-year survival rates afterwards, if they get the surgeries, are about 60 to 70%. Thankfully, our patient who I presented did not develop shock and did not need a surgical intervention. And so I showed you his one echo. He had at least 3 echoes during the hospitalization. It looked moderate at first, then moderate to severe on the repeat echo. This is the moderate to severe. So his may not have been as acute, and that may be why he didn't develop shock. So in conclusion, late presenting STEMIs that patients present greater than 12 hours still occur pretty frequently, up to about 1 in 6 patients in some of the data that I presented to you all. Late presenting STEMIs are associated with significant morbidity and mortality. We looked at a lot of mortality data, and these patients develop a lot of complications. And there's still room for improvement in pre-hospital delays, transport time, and door to balloon time in order to reduce total ischemic time and patient outcomes. And one thing I really want to stress after preparing for this talk and reading through the literature is if patients are presenting on average 2 hours after the onset of symptoms, and sometimes even later, we're already losing a lot of the battle before we even get there. So I think patient education is a huge area for potential improvement. So thank you all for joining this morning. I want to thank Dr. Gautam Kumar took the time to help me with this talk and go over my slides. Thank you, Dr. Williams and program leadership, family and friends for supporting me and co-fellows. Here's a picture of us from the holiday party this year. And here are my references. I'm happy to take any questions.
Thank you, Rachel. Very good, excellent review on an important topic. Another thing just more of a comment. You mentioned the low percentage of STEMI patients, relatively low, that take an ambulance to the hospital. This has come up multiple times in talks with patients sort of after their hospital care, is the sometimes enormous bills that patients will get for an ambulance ride, which I do, has come up to me just sort of off the cuff and talking to patients about it. They're like, have you ever gotten a bill for an ambulance ride? It's like, thousands of dollars sometimes. So I think that does sometimes play into a patient's decision to have a friend or a loved one drive them to the hospital instead of getting an ambulance ride. So
Absolutely.
go ahead. So sorry, Rachel, you were going to say something.
I was going to say absolutely, especially because a lot of these patients, the reason why they present late is fear, that it's going to be a false alarm as well.
Yeah, correct. Questions, comments from the group? Well, you did it. You Rachel, you did it. You managed to satiate all everyone's knowledge on the topic. So I guess would you, after your review, fall more on the European side of things, or you would just, patient comes in hemodynamically stable with a late STEMI without any signs of ischemia, et cetera, would you be supportive of opening the artery or not at this point?
I think we still do need more data, and we need more data in patients in the US. But looking at this curve, there's such a big difference. If this was one of my family members, they came in, 14 hours after an MI, and there's chance of really changing mortality, I think it does make sense. Again, we have to look at US patients, but this is pretty promising data from Europe.
Rachel, Stan Sherman, did any of the studies look at patients who had chronic angina versus those who didn't before their MIs, thinking that they'd had a chance to form collaterals and would do much better later?
That's a great question. That's not something I specifically focused on for the data that I looked at. But one interesting thing about patients who present later is oftentimes patients who've had prior MIs or old heart attacks have presented later because they thought, could this just be their chronic angina as a similar symptom, and it would just, go away on its own, go away with nitroglycerin, when it was really an acute MI.
Good review. Thank you.
Thank you.
Another question from the group. Dr. McGorisk is acting. He's commenting on the ambulance. Covered by insurance for ambulance usually means very steep copay. We need to do better getting patients assessed and back from ER waiting rooms back for required care. Yeah, I guess, right. If depending on your copay, a lot of times that's what people are paying when they get the ambulance ride. But yeah, just more on the expensive ambulance situation.
Absolutely.
Hey, Rachel.
Hi.
Steve Clements, how are you?
Doing well. How are you?
Yeah, that was absolutely great. I noticed that 1 in 300 patients who decide to take the car, fibrillate in the car. I've had a couple of experiences with that, in that patient just died in the back of the car. They kept driving, passed up several hospitals to get to Emory. When they got to Emory, they were like gone. So you always have to make that decision. I had to make it myself one time with a neighbor who something was going on, and my wife actually drove him to the hospital, and she told me that en route to the hospital she had to bam him on the chest 2 or 3 times.
Wow.
So there's always a decision you have to make, because the ambulance sometimes can be delayed, especially in Atlanta. You hear talk about that. So it was one thing that Andreas Grunzig said. He said it is better to have an open artery than a closed one. So I always remember that. So we end up cathing all these patients eventually. And of course, we find lesions other than culprit lesions that may need fixing, and then make decisions about opening up the culprit artery. And I was interested also in that first patient that had, maybe the second patient, the one that had the SC segment elevation, the inferior leads and the anterior leads, and you saw the wraparound LAD. So we made a big deal of that way back when it was first noticed. And Dr. Hurst used to always talk about the wraparound LAD. And, that kind of syndrome can be seen with less ST segment elevation in the inferior leads and a little more of the anterior leads with the syndrome of acute of right coronary artery obstruction. So I enjoyed that very much. You did an absolutely great job.
Thank you.
Hey,
Thank you,
Robbie.
Yep.
Stan here. So we're looking at all this and rewriting the guidelines. They're going to start this year. The other factoid that you need to know is that the majority of the country is not reaching the transfer times, from say a hospital that does not do PCI. It is not setting in at 120 minutes. So that's the majority.
Mm.
In our system, it's close to 60%, but we'll continue to emphasize the fact that for the reasons that is outlined, at least in the US, it's best to call 911 rather than rely on a family member or a friend. But bad things can happen, I've had many people just walk in the ER and saying they have a chest pain collapse and have VFib arrest, and if we were not there, they would not have been resuscitated. The other thing is that we have gone away thinking from door to balloon times. I think because majority of the country has met it, but the first medical contact to balloon time, particularly for transfers, is still not being met for the majority. We don't know what exactly to do about it, particularly after COVID. The ambulance systems were really saturated with the other kind of patient, and then because of the supply demand now and the fact that care is costly, a lot of ambulance services do not get to these places in time. I can tell you from our smaller hospitals that don't have PCI, it takes 40 minutes even for an ambulance to get there, and it should be like 30 minutes or so from the initial call. And particularly for Hillendale transfers to us, we almost never make metrics for that reason, even in our own healthcare system. So those are issues that are being addressed. Again, the half-dose lytic therapy is being talked about through smaller trials, particularly through Europe. Europe is a different model. In some countries like Belgium and Netherlands are so small that and there's so much saturation in ambulance services, and they have one dedicated STEMI center. It's not like multiple centers. They have nowhere to go to, and their transportation is very swift and efficient. So sometimes applying European models to rural Georgia is just not going to happen. I mean, so we're doing the best we can. I think we've done very well with door to balloon in this country, and we've achieved a significant drop in mortality from that. But the next STEMI is really cardiogenic shock. We see more cardiogenic shock now than ever we did before, and a lot of our efforts would now be, I think, in the near future, we write these documents, think about screening people with acute MI cardiogenic shock and how best to stratify them to the nearest center which can provide them support and rapid revascularization.
Thank you, Dr. Rabb, for your comments. Yeah, and you obviously have a lot of insight into the goings on with these. So do you think the United States will switch to similar recommendation to the Europeans in terms of late presenters and recommending PCI?
Robbie, I don't know that. I can't speak for our guidelines writing group, but the guidelines are from 2013. I'm on the guidelines committee, as you know. We're going to start thinking about these starting this summer. We have Europeans on board guidelines writing, so both from I think UK and I think France and Germany, who will provide the input to us.
Yeah.
I don't know exactly who they are right now. That's a confidential process, but I think by June we'll have a group together, and hopefully with some people from Emory on board that group as well. But we start thinking about writing this. It won't come out till end of 2024, but we're looking at all this right now. We're re-looking at all this. This whole thing is being re-looked because the societies and physicians are demanding a new document, and it will be a very comprehensive document as we go forward.
Well, your secret's safe with us.
Secrets are not going to be out till the end of 2024.
And by the way, my comments on the ambulance, by no means am I suggesting that people should not take an ambulance to the hospital when they have a STEMI. And there's more comments from Dr. McGorrick. He's right. I mean, absolutely, you should call an ambulance. You should encourage your patients to call an ambulance if they think they're having an MI, just like you said, because they can alert the ER en route. They can obviously treat you en route, blah, blah, blah. All right. Well, everybody have a great Friday. Go Princeton, and we'll see everybody next week.
Thank you, everyone. Thanks for joining this morning.
The preceding program is copyrighted by Emory University.